Welcome to World Medical Elites. This is Shirley Crest-Dudley, and today we will be discussing MSOs with our guest, Dr. Ford Brewer. Welcome, Dr. Brewer.
Thank you for having me, Shirley.
We had Dr. Brewer here earlier describing his role in prevention and primary care. And primary care is making a big change towards prevention, and that's the core of our topic today. Now, a little bit about Dr. Brewer. He is the founder of PrevMed Health and PrevMed Network, and is a board-certified preventative and occupational medicine physician, internationally recognized speaker, and educator. He learned early on at Johns Hopkins University that many disabilities and diseases brought to the emergency department are preventable. He has since dedicated his career to help spread knowledge about how to prevent the most common chronic and debilitating diseases, such as type 2 diabetes, heart attack, and stroke, as well as improving patient care by educating healthcare providers. He founded PrevMed Health as a resource for physicians and other providers stuck in the rut of working harder and making less. Okay, let's get started. Dr. Brewer, what is PrevMed Network?
It's technically the term is an MSO. It stands for Managed Services Organization, but that doesn't really explain very much. What it does is it helps doctors, nurse practitioners, other providers get ready for the big changes that are happening in primary care payment. And those big changes are a really big deal. It's going to impact the careers of all primary care practitioners. It's reached a tipping point. We are getting into payment which supports prevention. In the past, it's always been fee for service, fee for service, fee for service. And that's the easy way to set up insurance payment. You know, you try to figure out, okay, what's something that's objective? Writing a script. So guess what? Things revolve and they have for the past 50 years in the insurance payment for primary care around writing scripts. Doctors are like anybody else, nurse practitioners. They do what they get paid to do. So people wonder why. It seems like the doctor spent 7 minutes, and believe it or not, that's the average in a lot of studies. 7 minutes average to see a primary care patient. They come in, they write a script, and they leave. Many people have complained about that, and unfortunately, it's because it's true. The reality is, writing a script is not nearly as important for a patient's health as the patient's health behaviors. You know, starting with, well, did they actually take the medication? Did they know that they needed to? Did they take it appropriately? But way before that, lifestyle. Nothing impacts an individual's health like the decisions that individual makes on lifestyle all day, every day. How much to eat, what to eat, how much to exercise, how to exercise. So those things are so much more important than prescriptions. But again, you go back to how insurance was built. It was built on fee for service, and that's had big negative impact on our healthcare, clearly in the US, but in most parts of the world for decades. That's changing after decades of trying to get into a different way of paying. That has started to happen. And it's actually compared to fee for service. It's called fee for value. If you start looking this up, you'll start seeing fee for value a lot. And when you see that, you realize that's what's going on. The bottom line is doctors, nurse practitioners, other licensed providers, PAs have to learn a whole new way of practicing. It's not coming in, seeing trying to figure out very quickly, pat your patient on the back. How's Uncle Freddie? Aunt Sue, let me write a script. Let me get out to the next patient to write a script, which is what you learn, unfortunately, once you get out into the fee-for-service world. these licensed providers have to learn something entirely new. They have to learn to do what keeps their patient healthy. And that is very different. It doesn't take 7 minutes. It takes a lot longer. It's communicating with the patient to help understand where they are in terms of their major drivers for health behavior, listening to them, and then helping them figure out how to problem solve and get to their best health. Totally different way of doing this.
So it sounds like you're answering what kinds, but if you can elaborate a little bit on what kinds of skills and knowledge that they get from joining PrevMed network.
So some of it gets very technical as well, and thanks for asking about that. So I started learning that some of the getting beyond generic prevention. So as you mentioned in the introduction, I started off my career as an ER doc after countless preventable heart attacks and strokes, decided I needed to go learn prevention. I went to Johns Hopkins, loved it, did well, and ended up running the program in prevention, training doctors at Johns Hopkins. So I knew that part, how to actually practice that way very, very well. I knew how to train docs very well, but fee for value in insurance world has a whole new set of technical skills. And I learned those working with a company called Physician Partners. They're based in Tampa, Florida. They are one of the largest Medicare Advantage programs in the country, and therefore in the world. One of the core technical skills that we do had very much to do with what I trained their doctors for doing, and that is risk assessment. I'll give you an example. Diabetes is incredibly prevalent, and depending on the population you're looking at, the physician group or NP group that you're looking at, the practices, usually at least 2/3 of diabetes is totally missed until too late. In the fee-for-value world, one of the most important parts and technical skills is risk assessment. So one of my major jobs working for Physician Partners was teaching their 80 doctors how to diagnose diabetes much earlier. So if you get a little bit more concrete, here's something that would demonstrate success on my part. A typical doctor would come into out of a primary care fee for service world where they're writing scripts, and they would actually make an appropriate diagnosis in your typical 65-year-old Medicare patient at about 2% of the time. The reality is the prevalence is far greater than 50%, closer to 80%. And as I worked with those docs, showed them how to focus on that issue, how to evaluate the metabolism, not just tissue injury, and then how to code that, then that made a big difference in terms of revenue for the doc, major savings for Medicare, because once a patient realizes, oh, I thought I just had a touch of sugar, I've got full-blown diabetes, their probability of going into the hospital and losing a leg because of that out-of-control diabetes plummets. So it's good for Medicare because they're not spending that kind of money. Most of all, it's good for the patient. At the end of the day, it's really good for the doctor and the doctor's family, because even though you're spending more time with an individual patient, it's clearly a thing of slowing down to speed up, because you take the time necessary with the patient, you help them understand what they've got going on, you learn the ways to technically describe that to Medicare and the payers, you get all of that done, and then the work proceeds rather than just going around in circles like it does in a fee for service world. Technically, one of the major, so it gets into coding as well. And what I mean by that was one of the major codes that I had to teach the organization there, as well as the doctors involved, was a code, E11.65. Again, that sounds very concrete, very technical, and it is. But it's basically showing this patient has full-blown diabetes, and we've documented at least one episode of hyperglycemia, high blood sugar. The reason that code makes a difference is because it makes a huge difference in terms of the patient's risk. And Medicare knows that. When you pay for as much medical care as Medicare pays for, you know which items, which conditions confer risk. And that's one of the key technical risk assessment things that we do for providers. We also get into some things that they're starting to learn now, things like HEDIS, which most providers have heard of. It gets a little bit technical than just using the term HEDIS. We help with things like CAPS and HOS. Most people have not heard of CAPS and HOS, but CAPS and HOS are very important because Medicare is now triple weighting those. CAPS is it's basically a patient experience survey. And you have to know, the providers really have to know how that works. Many of them, for example, think, well, if this is just patient experience and patient satisfaction, all I have to do is just write narcotics and they'll all be happy with me. Well, that's jaundice, and it's not really accurate, and it doesn't work. In the CAPS experience surveys, they take that into account, and they end up looking more at things like, okay, just how long did it take the patient to get in to see the doctor? What were the things that changed in that evaluation that work with the doctor? Things that are really objective. They sound like a patient satisfaction survey, but they're far more objective than the jaundiced assessment would be. I'll make one more comment about HOS, and then I'll be quiet and let you talk for a second. HOS is the health outcome survey, and basically what that's talking about is, what does the patient know about their health, and what are the outcomes that are occurring? So that gets back to what I said a few minutes ago. Real health is not about how many prescriptions you wrote. Real health and health impact is, what does the patient have? What do they know that they have? What is their assessment and understanding of their risk and their health drivers? And how are you impacting those? So it's no wonder that once you're starting to get into that, which is so much harder than, for an insurance company, it's harder to do that than just pay for writing a script. But that work has been done. That's working. And as I said before, we've hit a tipping point in our country over compensation for primary care docs. Those of us that don't learn how to do this are going to be in a world of hurt.
This is really good information, and especially when you mention coding, because I know that is a bear for many providers, not something they look forward to doing. I'm looking at your website right now, prevmednetwork.com, and your online training center, seeing physician's training manual, the quick coding guide, the HCC MRA coding tools. So it looks like there's a lot of tools and offerings for providers here. Can you tell us a little bit more about your online training center?
Well, yes. And again, thanks for your attention to that level of detail. When I was the chief science officer for Physician Partners, by the way, has 150,000 patients under full risk, and they're a 5-star program, meaning their top 10%. Actually, I know from they're actually higher than that, more closer to the top 5% of all providers in this space. So it's very high quality, and they're doing great financially because you do great work. It's like Toyota. Quality is not expensive. Quality actually ends up being the most cost-effective thing you can do, and that works in healthcare as well as cars. But back to your question. So one of the things, I don't agree with anybody on everything. I loved my work there, but one of the things that frustrated me was I spent a lion's share of my time going around and repeating the same technical coding things, for example, to doctors and nurse practitioners. As you and I talked last week, I have this thing about scaling that kind of message. I do videos. I've got a YouTube channel. So that was one of the things that I felt that we should go ahead and make a learning resource center. Couldn't get the support I needed to do that for physician partners, but when I started my own program, developed it and ran it in Alabama with a network of docs and clinics that I owned, and that's what I did. I went back and took all of that technical coding information, HEDIS information, CAPS, HOS, and created videos. So, I realized that videos are not a replacement, but, again, it gets back to old Toyota concepts. Toyota has a thing about push versus pull. And what they're talking about there is it's better to have a pull, meaning when the patient or the consumer wants something, they need to be able to access what they want, when they want it, at the cost that they want. Why did I go down that path? Well, when I was teaching this at Physician Partners, it was everybody had to take time off, schedule downtime for their clinic, make a trip into headquarters or the regional space. I needed to fly down. We would, do a day of presentations and Q&A. And there's clearly a place for that. But they needed to be able to have a set of videos which covered this same content. And given the way you're doing that, you can do a lot more videos, create a lot more time, get in a lot more detail, and actually create more of a performance evaluation. So that's what we did. We created detailed videos covering each of the major coding sections, each of the major codes. We also set up a learning evaluation component. So once you complete, depending on the section, it could be 5 to 25 minutes. Once you go through that, then you have a self-evaluation component or an evaluation component. We give you a quiz. What did we cover in this video? Here are the questions. You got to get the answers correct, or you need to go back and try it again. And here's some resource information to help you figure that out. So when we would still have our big training sessions in the Alabama project, but these people came armed with already having seen the videos, gone through the Learning Resource Center, and it was a totally different experience. It wasn't spoon feeding babies in the area. It was having a conversation with people that knew the content. We also, as you mentioned, you need to have, this is way too much information to expect somebody to just learn all at once and keep in their head. So you need learning guides, you need desk guides, you need a tiny guide to put in the pocket of your white coat. And we did all of those, and we have all of those available, and that's part of this service as well.
That's very impressive. It sounds like you're going to improve providers' documentation and their performance also. In looking at the website, it looks like it also encourages collaboration and professional development among the members. And do they become members? How does that work?
So that becomes a negotiation. So when you go back and you remember how fee for value or preventive insurance coverage works, you begin to realize this is risk. And again, you go back 50, 60 years ago, insurers knew that the most important person in the healthcare team that they needed involved was the primary care doctor. That's the doctor that basically provides that interface between all the technology of medicine and the specialties and the patient. So they made a few trials of actually setting the docs up where they could achieve, they had risk in terms of whether or not somebody got sick or whether they got better. So if somebody got better, the doctor made more money. That's capitation and risk, both of which are very much a part of this kind of program. Unfortunately, well, whether fortunate or not, you cannot pick just any partner in the world to join your capitation program or your risk program. One doctor that doesn't care, that performs poorly, can ruin the financial results for other members of the team. So we have to be very selective in terms of who we bring on board. And once we bring somebody on board, we continue to do that work with them, but we also share positive outcomes. When you get into this kind of discussion, you hear you'll hear terms like upside and downside. Upside is the ability to share savings. Downside is, sharing risk. The full and the most rewarding, financially, the most rewarding arrangement is to have arrangements where your provider team and payer team are at full risk. But that's, again, that full risk is exactly what it says. It's also the riskiest environment. So the way things work now is you start with bonus programs, and you start with, okay, well, most docs forget to get an A1C on a patient. So you get a bonus when you do appropriate A1C levels. Most docs forget, as I said earlier, most docs forget to or they don't make appropriate diagnoses, like we talked about with the example with diabetes. You'll get bonuses based on that. So you start with, in terms of the transition into a full risk environment, what we do is we take docs that are used to today's mostly fee-for-service world and help them transition into that full risk environment where they can make the most money, be at home with their family the most, and have the healthiest patient population. That takes a couple of years. It takes a couple of years for the doc to learn it. It takes a couple of years for a doctor to transition his or her practice, or a nurse practitioner to transition his or her practice from fee for service into full risk. And we help them every step along the way. So again, that may sound a little bit nebulous. It may sound overly technical and detailed, but that's why, again, it took so long for Medicare and the other payers to start getting to this place. If you think that, some people listening might be thinking, well, he keeps talking about how this is happening. It's not happening in my world. Well, there are very few people that are saying that at this point. But in case you are, just a couple of statistics. Back when I started with, so it originally started in South Florida. That's how Physician Partners was involved in some of the original demonstration projects. In the 90s. The when I got involved with physician partners in the mid-teens, about 21% of Medicare was Medicare Advantage or fee for value.
Mhm.
At this point, 8 years later, we're already at 48%. Half of Medicare folks are in Medicare Advantage programs. Medicare's commitment is that by 2030, it'll be 100%. Now, the pontificators in that space, like the Kaiser Family Foundation, would say, no, it's going to take a lot longer than that. And I think that's true. But the point is, again, Medicare is clearly on the way to getting there. You haven't seen that much of that in the private payers yet, but they're headed that direction as well. And it's a good place for all of us to be. It's better for the patient. It'll be better for the providers, and it'll be better for the payers.
Mm-hmm. Sounds like it. Can you give us a peek? Are you working on any new programs or any new initiatives?
Well, we're just in when you look at it from that perspective, doing this on a global or a national perspective is new for us. As I mentioned, I did that a few years ago for physician partners. That was Florida only. Then I mentioned that I started my own program in Alabama a couple of years ago. That was Alabama only. But I also mentioned that I have a YouTube channel. And as part of that YouTube channel, I've got 125,000 subscribers. That YouTube channel has formed a little side practice. People listen to that and they say, I really like what you're talking about and what you're doing. I'd like to come see you. So in the midst of all the stuff I've been describing, I've done that on my YouTube channel for 8 years. On some related activities, I have had to develop and maintain an active license in all 50 states. So now what we're doing is we're putting that together. Telemedicine, all 50 states, and fee for value, Medicare Advantage, the MSO network. So that's what we're doing now. We're starting to create access for patients, which doesn't require them to make to get up and bury a whole day every time they need to go see the doctor. Patients are starting to respond to that. They're getting very excited about it. And it looks like we're rapidly going to use up all of the provider time that we have, and we're going to need other docs to join us, docs, NPs, folks to join us for a national telemedicine type of practice.
Oh, that's very interesting. So I understand that you have patients all over the world, but are you saying then that a doctor or extender or provider anywhere in the United States could take training from you and potentially join you?
Oh, yes. Thank you for clarifying that. That's exactly what I'm saying. Providers all over the country.
Wow. So if a physician or another healthcare provider is interested in joining PrevMed Network or learning more about it, I've put the contact information on the screen, but can you give us some steps about how to get started?
The simplest and easiest thing is to call the numbers or send an email to us, info@prevmedhealth.com, or call that number, 859-721-1414. As I mentioned, I think you tried to get a little bit more detailed and concrete a few minutes ago when I started talking about how to join the group. And I think I remained, like I said, a little bit nebulous because once you get started with us and get started on the training process, we don't train people just for the fun of it, and we don't really at this point have a fee-for-service module where we say, oh, you want to get training and all this and go off and do it on your own. Here's, pay us a few $100, a couple of $1,000, and we'll train you, and then you go do your thing. We don't do that. We are forming a network. So there's that. We have to evaluate where you are, what you know, your motivation, and you need to do that with us. And then we negotiate a cost sharing, risk sharing, revenue sharing, profit sharing arrangement.
So if they're not ready to make that kind of commitment, can they access the resources on your website?
We're getting a lot of push for that right now. And yes, you can sample it. We don't have it where you can learn all you want and then just walk away. Because the bottom line is we think that's a part of our secret sauce, a part of our value prop.
Well, I know a lot of providers would like to get off that endless hamster wheel. So it sounds like you've got some amazing information. Did you want to provide anything in conclusion?
No, I just wanted to say thank you again, Shirley. As you can tell, I'm excited about what I do. I was looking for this. I hate to tell you how old I am, and I guess I won't, but it was over 30 years ago when I graduated from Hopkins and became faculty there in prevention, and became rapidly disgusted with the state of healthcare and the problems and the errors and the waste driven by fee for service. And it's just, I could not be more excited about what's happening. I wish it happened 30 years ago.
I agree. Well, if you're interested in more information about PrevMed Network and Dr. Brewer, you can see his contact information, the email, phone number. Also follow him on social media. You can find him pretty much everywhere you see below at PrevMed Network. So thank you, Dr. Brewer. Thanks for coming again today.
Thank you very much again. Talk to you later.
Yes, and thank you all for listening to another segment of World Medical Elites. We are your top source for provider social proof. And if you're a healthcare provider, please go to World Medical Elites and sign up for your free listing. Thank you.